Hello, I'm Joseph Bavaria from Philadelphia, and today's topic that we're discussing at the STS Roundtable is thoracic aortic surgery, and in particular, the new trials and the new applications of TEVAR in the thoracic aortic surgery space. And I have a number of experts with me who I'd like to introduce.
My name is Khoynezhad. I'm a cardiovascular surgeon for Cedars-Sinai.
Hi, I'm Eric Roselli at the Cleveland Clinic.
My name is Himanshu Patel. I'm at the University of Michigan.
So Himanshu, myself, Eric, and Ali would like to discuss some of these new events and new trials, and actually just new happenings and what's new in thoracic aortic surgery, especially as related to TEVAR in the proximal aortic space. So to begin with, Ali, I'll start with you. What's your take on the arch branch grafts that are being used now? None of them are really available on label, but they seem to be being used not only in the United States, but in Europe, in Canada, and elsewhere.
Yes, that's certainly a very exciting area, Joe, and very happy to see that at least two companies in the U.S. are starting their early feasibility. In fact, Gore, which I know you've been an active enroller in, has just finished the early one, and we're going to have expanded centers and additional centers that are going to be participating in that. So Gore has a thoracic branch stent graft that allows us to do a zone 0 and zone 2 arch device. There's a Mona Lisa device that I'm sure Eric would be happy to say a little more about it, and that's a terrific study that is only pertains to zone 2s. Then there is a Bolton device. It's called a 2-branch device, and there have been already close to 20, I want to say, European patients entries. No studies yet in the US. And that has been a little bit on the slow side, but the device, generally with people that I've talked to in Europe, has had very good results in terms of outcomes.
So can you talk to us, Eric, a little bit about maybe the differences between the Valiant or the Medtronic Zone 2 system and some of the other ones that are out there?
Yeah, sure. I think, as Ali was alluding to, there's sort of two classes of devices that are in development and actually becoming increasingly more available. It's the single branch devices, the Gore and the Medtronic Mona Lisa, and then the double branch devices, the Bolton, which hasn't come to the US yet, but also a Cook 2-branch device, which we've had experience with in the IDE as well. And I think that what we're going to learn as we apply these devices is really who we're going to apply them to. As investigators, as we've become more, I think, confident in the reliability and ability to deliver these safely, we'll see a rapid increase in their use.
Right. So, Himanshu, on that, I think Eric is right on. Let's focus more on Zone 2 devices right now, or Zone 1, I suppose you could use them as well, because that would go either way. But for the Zone 2 devices, which are right now the Gore device and the Valiant device, there are others probably coming down as well. Where do you see these being used? Because I think Eric's right. We haven't really quite gotten our hands around exactly what the indications will be and who will get these devices. And is it going to be an expansion of, say, more than a simple placement of an extension of the standard descending thoracic aortic device and kind of relegating the carotid subclavian artery bypass to the history bins? How do you see these devices being used in their entirety?
So I think in the current version of these devices, I think the obvious application is in the treatment of distal arch aneurysms that extend more proximally. I think the interesting thing about these devices is whether down the road as stent graft technology evolves, whether they'll be applicable as well for proximal aortic aneurysms that extend more distally across the arch. But right now, I think the paradigm is really for distal arch aneurysms that extend proximally across the aortic arch.
So really, basically utilizing it in Zone 2 as a standard Zone 2 replacement.
Isn't the single branch really more like for descending disease that encroaches on the arch, and the 2 branch is more for the stuff that's really where the pathology is in the arch? I mean, wouldn't you think about it?
I totally agree. I mean, the single branch graft really requires, for the most part, requires a landing zone that's reasonable in Zone 2 or Zone 1.
Right.
Whereas the 2-branch grafts really are, it's a pure Zone 2. I mean, it's pure Zone 0 landing zone.
Yeah.
How would you think the Zone 2 grafts will change, or will they change the way we manage the initial index proximal operation for type A dissection?
Type A dissection?
Yes.
Okay. So
Will it or will it not?
I think it will be definitely helpful for some a subset of patients that have residual false lumen and enlargement within the first 5 years. And Mona Lisa, Medtronic device, Autogore will allow us to cover those entry tears, because majority of those patients I see have a normal arch. They hopefully had a decent hemiarch with an aggressive replacement of entire ascending aorta. So you really need a device that seals up right at the subclavian or just before the subclavian, and hopefully take care of the false lumen expansion in the descending thoracic aorta. And that I see a big utility of it. In fact, the Mona Lisa and the Gore, I think, will allow us to now treat the bulk and the entire of the descending thoracic aorta endovascularly. If you remember, based upon numbers, 60 or 70% of the descending thoracic aorta encroaches on subclavian artery. And in the past, in those cases, we either cover them cavalierly or we started doing carotid subclavian bypasses transposition. So I think it's a very valuable device to have, and I'm very excited about it.
So Eric, you know, there's a broad trend across the globe towards increasing use of the frozen elephant trunk. Out of China, we have large patients populations that are getting frozen elephant trunks for type A dissection. More so in Europe with the couple different branch devices that are available there. And we in the United States have been kind of either putting in antegrade delivered frozen elephant trunks as separate pieces, or maybe coming in with a stent graft later on. How do you see these branch grafts affecting the index operation for type A dissection?
Great question, Joe. And it's interesting, as we start to have new technologies, we actually start to look at the diseases a little bit differently. So I hear more conversation about certainly experienced centers being more interested at the time of a type A in dealing with maybe the innominate and left common carotid, so that they provide the word you use is platform, where you could land a single branch device to deal with left subclavian later. That's a cool idea. I operate on a lot of patients who come back with chronic dissections, and although the arch is often spared of aneurysm, it's most of the time still dissected, despite really beautiful operations where, you know, the distal anastomosis is done with a nice hemiarch, multiple layers, we sew it together, and increasingly, I notice more often than not, there's a tiny little pinhole or something at that distal suture line that keeps that false lumen open in the arch. I think it's important for us to address that arch better. And I think that and this doesn't get talked about very much, but it's there. And if you don't have healing of the dissection through the arch, then a single branch device may not really offer you a whole lot of advantage later on in these folks. And so putting some sort of frozen elephant trunk or doing a little more in the arch to stabilize that makes a lot of sense. Putting a stent graft in to push those layers together and make sure you don't have those little pinholes that happen. Not because someone can't sew, because they're sewing to really crummy tissue.
So what you're saying really is that maybe that the availability of these branched arch devices might change a little bit the actual approach that we use. So now we'll change our operations to fit these new device availability. Is that kind of, you see that happening?
Yeah.
Like, for example, instead of hemi-arches, maybe more zone 1 or zone 2 arches,
right,
which are pretty straightforward arch operations, really.
Right.
Not that much different, frankly, than a hemi-arch.
Yeah, you keep the suture line in your face, right?
So let's shift gears a little bit and go to TVAR for type B aortic dissection. So as many know, the FDA recently gave out a very liberal approach to the labeling of TVAR for type B dissection, including acute dissections, acute complicated dissections, acute uncomplicated dissections, chronic dissections. So Himanshu, how do you see this new FDA expansion of indications affecting the paradigm for treatment of type B aortic dissection with TVAR?
So I think that thoracic stent grafting for acute type B dissections is actually a great idea. Certainly for malperfusion or rupture cases, those emergent cases that require intervention. I think in the setting of elective or urgent, rather, indications for stabilization of the aortic pathology, I think that data is evolving slowly, but my suspicion is that for a certain subset of patients, thoracic stent grafting may be very, very appropriate early on to heal that aorta. I think the biggest question in everybody's mind, frankly, is whether applicability of thoracic endografting for chronic type B dissections is going to be appropriate and efficacious. I think there are several ways to think about it. So we've been actually pretty conservative in the treatment of chronic type B dissections because, at least in our experience, we've seen growth. And if you look at some of the IRAD data, which suggest partial false lumen thrombosis of the aorta will increase mortality, essentially what we're doing with thoracic endografting for chronic type B dissections is partially thrombosing their false lumen. So we've seen aortic growth in that setting. There are certain anatomic substrates for patients that present with chronic type B dissections. So for example, all your visceral and renal vessels coming off the true lumen, that may be very favorable. And I think the other thing that needs to be talked about is what is chronic. So a 2-week chronic or a 2-month chronic or a 5-year chronic are very, very different kinds of endovascularly amenable approaches.
So what do you think about this, say, focus on the chronics, Eric? I mean, it seems like, we just had at the STS yesterday a presentation by Joe Caselli's group looking at basically chronic dissections, TAAAs, repairs in patients under the age of 50 as an open procedure with really reasonable results. So where do you see TEVAR for type B dissection in chronic dissections? As Himanshu says, real chronic dissections, not ones at 2 to 3 months. Where do you see that problem with our decision-making process, our conundrum regarding TEVAR versus open cases in chronic type B dissecting aneurysm, especially when you know that many of these patients will have their have landing zone issues up in zone 2 and zone 3?
Well, I think certainly as Joe Coselli showed us, those operations can be done safely, but remember that a surgical outcome study is the numerator of patients. And so what we need to understand better is the natural history. And I would argue that for a young group of patients, if you look at the long-term survival in patients who are walking around with chronic dissections, it's way less than what it should be for people who don't have atherosclerotic coronary disease and other more common causes of death. We want these people to live longer. And I think if you look in a little more detail at some of these outcome studies that look at chronic dissection patients, in our series, we tried to figure out what the predictors of long-term survival were, and repeatedly they were this diameter at the diaphragm came up in these folks, which to me says that we're operating on them with really late-stage degeneration. If we're going to reverse the natural history of the disease, I think we need to be more aggressive up front. We're going to need a lot of data over a long period of time to prove that, and certainly we have to do it safely. But I think TEVAR offers a good option. And there's new techniques that we're learning as we're applying more stent grafts in the chronic state. For example, one of the things that we've been doing is actually ballooning the chronically dissected stent graft
At the distal.
all the way through the thing. Get that true lumen expanded now that I got the device in.
That's very controversial, as you know.
We got some data brewing that we'll be showing soon, but I think that we want to promote remodeling of that aorta sooner than later.
I think that what I'm hearing from you two anyway, and I'm going to get to Ali in a minute, is that there's probably a very we may see and may want a shift at the index dissection to put stent grafts in more patients so they can remodel earlier. The data is a little sparse, but it certainly makes a lot of theoretical sense. It doesn't really answer the question of what's the right procedure to do in, say, a youngish patient under 60 who has a chronic dissecting aneurysm, whether you should do a TEVAR or do an open operation. So let me get to Ali about the idea of how do we identify patients who have acute type aortic dissection that are uncomplicated. Complicated are easy. Everybody's going to stent graft complicated dissections. But for uncomplicated dissections, what subgroup would you be more aggressive using TEVAR at this point? And also, what would be the timing of that operation?
That's a great question. So now with the recent FDA approval that allows us to do this procedures much more easily and within the IFU. So I think there is a subgroup of type B dissections that we called high-risk uncomplicated. And there are multiple studies, mostly coming from IRAD, but also some centers such as Korea and Asia, that shows there are a subset of patients that have a significantly higher risk of early rupture, early rapid expansion that would definitely benefit from stent grafting. And that's what we would offer with the type B dissection early on, if it's completely uncomplicated. If there is no signs of malperfusion, if there is no signs of, and that's not only radiologic, but also obviously clinical, which is very important, no evidence of perforation. And those are patients typically that have a very large initial onset false lumen. Those are people who have over 4 centimeter total aorta at the beginning of presentation, over a 22 millimeter false lumen. People who have partial thrombosis have shown to have a significant expansion. There are a subgroup of patients who have convexity, exoconcavity, location of the entry. Our group, actually, we have one of the longest follow-up of acute dissection, over 5 years in data, and all those are with imaging backed up. People who have a very large entry tear, especially in the lower descending thoracic aorta, we saw a lot of malperfusion in those. And people who have multiple large on top, they have a faster expansion as well. So those are patients that I'm initially a little more.
So let's expand that a little bit. The patients who have, I think the imaging now is good enough, Himanshu, where we can actually measure and see how big the proximal primary tear site is for type B dissection. If you have a large primary tear site in your patients, what do you do with those right now?
For an uncomplicated type?
Uncomplicated, yes.
I think what we do is, obviously, if they have hard criteria for intervention, we intervene on them. But we don't specifically look at the size of the entry tear to determine whether somebody requires treatment. We look at whether the patient's blood pressure has typically been more difficult to control, whether the baseline aortic dimension is increased, whether they have either an IMH or a double barrel dissection, those types of things. And I think one of the other things is the age of the patient. So sometimes I think some of these younger patients, they're going to have a lot longer to grow the aorta. And maybe in those patients, then you may be more inclined to treat them with an endovascular approach early to kind of provide some seal. Not really based on any data, hard data per se, but I think that's one way to think about it.
Yeah, I think that the concept of the high risk, uncomplicated dissection is actually the key thing at this point.
One more key element that comes into it, if we have models that predict basically reverse aortic remodeling, that means if we have a model of a certain patient based upon anatomic pictures that we know at 6 months or a year they're going to have a single lumen aorta, I think that allows us to be more aggressive for those uncomplicated high-risk patients as well. And we actually reviewed some of the imaging data, and the size and the number of entry tears were not important, but the size and the location of them were important. So we were able to come with a 4 classification in the type 1 and 2 classification, and there was a JVS publication, had almost close to 97% reverse aortic remodeling. So yeah, if you have a picture like that and it's a high-risk uncomplicated, that's a no-brainer.
I think the biggest issue, frankly, is actually when to do these patients. I think,
We
you're a
haven't
risk,
talked about it
the thing about, you don't generally have a risk of retrograde type A dissection, at a very high percentage in patients who are medically managed appropriately for type B dissections. On the other hand, reports of retrograde type A dissection, when you intervene on these patients with a thoracic stent graft, is not small.
Yeah. That's
correct.
And I think, obviously, like personally, we wait a couple of weeks, but I don't know whether by waiting a couple of weeks we induce remodeling in that distal aorta that makes the aorta less likely to completely collapse.
So let's since we only have a limited amount of time, and I want to go to ascending aortic stenting for a second. But before we do that, really quickly, if you have an uncomplicated type B dissection with high-risk features at your hospital, we'll go right down the list here. When do you put a TVAR in?
I do that between 1 month and 3 months.
Yeah, within the first 90 days.
We do it between 2 weeks and 6 weeks.
Yeah, we do it within the first month.
Okay, there you go. So that's good. Now, last subject I think is very interesting, and I think it's very important for us to when we discuss ascending aortic stenting, which really is ascending aortic stenting for type A dissection, which is the main issue. And I know we have some early trials, early feasibility trials going on in the United States right now, is a very different concept than a standard issue concept regarding a zone 0 arch operation. So one is a TVAR for an isolated ascending aortic condition. And the other one really is an application of TVAR for an arch condition where the landing zone, where there's an appropriate landing zone in the ascending aorta. Either that landing zone is native aorta or that landing zone has previously been treated by Dacron, by us, in the first stage operation. So Ali, since you're involved with this, where do you see type A stenting at this point, or ascending or extending in general?
So with the new changes with early feasibility within the IDE, that helps us basically with a lot of these clinical trials with special devices that are in unmet need area. We were able to apply for one about 5 years ago with Rod, my mentor and colleague, and we have been approved now for close to 3 years. And I think that allowed us to specifically target patients that were high risk. These are typically redo patients or patients who have a type A dissection with multiple medical problems, to treat those isolated cases where you have a perfect entry tear between the SDJ and the innominate large one that you can cover. We were able to successfully treat 9 patients so far without mortality. We had 1 stroke and 1 type 1B endolate. So I think with those criteria, we can obviously treat a certain patient. Now, having said that, if you look away from type A dissection, the applicability or use of this device in isolated ascending aorta is going to be small, because there are very few patients that have isolated ascending aneurysm. There are a lot of patients who have, pseudoaneurysm of a vein graft. They have basically maybe, ulcer or various things that can be easily treated.
Those are very a small subset of patients. True. So it should be noted that there are 2, as far as I know, 2 FDA-approved early feasibility trials in the United States for isolated ascending aortic stenting for type A dissection out of Los Angeles and Houston. So Eric, I know you've done a few of these and have some experience in this. What's your take on ascending aortic stenting for type A dissection or any other etiology?
Currently, I'm practicing medicine. And in that experience, we've treated over 35 patients with ascending stent grafts because, they needed something done. And in the experience, about half of them have been Q type A dissections. And what we've learned in that early experience is we really need disease-specific devices. So as Ali was saying, 2 of yours were type A dissections, and the others, there are 3 of them. Yeah. Completely different things. I think if the current devices are a columnar tube with some wires attached to it, that's fine for a straight segment of the aorta or some focal disease in the ascending aorta like a pseudoaneurysm, which is uncommon. You cover that hole, it seals, it changes. We learned little things about sizing the device. When we're talking about treating type A dissections, we have to understand that space where we're putting the device. We really need a device that's designed for it. The ascending aorta is not a straight hose. It's a very curvilinear structure, and the forces are totally different, and the disease is different. Having said that, though, our treatment goals are probably also different, too. So in IRAD, up to 23% or something like that of patients are not getting offered any therapy for type A dissection, and they die quickly. In our institution, a lot of large centers like you guys, it's probably, somewhere between 5 and 10% or something that we're not offering therapy to. We need something for those folks. And if we can cover the entry tear and get them through the acute phase, then we put them in an elective situation, so we can think about it as a bridge to therapy. We may be able to offer them definitive treatment later on, or maybe the stent graft, if it's designed for that, will actually offer some definitive therapy to the ascending aorta. So we need a lot of help to kind of push that forward. It's great to see the work you're doing with the IDE and what's happening in Houston, but we really need disease-specific devices for that.
Yeah, we got to distinguish between the 2 devices. The one that Houston that you're talking about, that have been so far no patient entry yet, is a device that is already approved for descending thoracic aorta. So it's an off-label use of a device. The only really IDE that has a specific, disease-specific ascending aortic indication is the Medtronic currently.
I think, so the first comment is, I'm all for elective type A repairs, Eric, but I think the one of the biggest steps that needs to be made for patients with type A dissections and endovascular repairs, improvements in imaging. If you look at some of the studies that have been done with anatomic characteristics of it, a lot of the scans that were brought were really not of adequate caliber. We all see little entry tear, or re-entry tears rather, in the ascending aorta that are really not visible in treatment, that are really not visible on the preoperative CT scans, which may alter, the treatment.
Yeah, I think type A stenting of the ascending aorta does have a little bit of a long way to go. We're not there yet, and imaging is going to be key, and actually translation of echo imaging is going to be huge. They're going to have, we as surgeons who do a lot of thoracic aortic stenting in the thoracic aorta, have always relied very, very significantly on the CT scan and high-resolution CTA. But in this particular instance, we may have to change up the way we do things, which also means that industry is going to have to change the way they design these stents and actually think about how they are placed in the ascending aorta, because most of us actually are, in the end, are looking at the TE, because the CT scan is sometimes already passé in history when it comes to a type A dissection.
That's a dynamic process for
Exactly,
sure. Yeah.
exactly. So last question for Himanshu on this. Do you think with type A dissection that it's going to require more of a platform of different devices and combinations of devices to treat type A dissection, or do you think one simple device is going to be able to do it?
I don't think one simple device will do it, because I think you have to account for, I think part of the problems with thoracic endografting is basically we have a infrarenal device that's used in the chest. And for type A dissections, the anatomy, the pathophysiology is so radically different that I think you're going to need to have a fundamental shift in the engineering of the device that can incorporate root pathology along with branch vessel pathology.
Well, it's an exciting time for us to be involved with this. TEVAR in the proximal aorta is really becoming a significant part of what we do, and will be more so in the future. It was interesting to me, and you guys can say something to this, that when you talk to industry, literally 70 to 90% of all investment in R&D in the thoracic endovascular space is now towards the proximal aorta. The descending aorta and the abdominal aorta are kind of settled at this point. So it's a very exciting time, not only from a physician standpoint, but from an industry standpoint. So it's incredibly important that the STS, as well as the cardiac surgery community, embraces this. I think that I have agreement from all of you on that one.
Totally. Yeah, it's about time. That's where most of the disease is.
I have to agree on that.
Yeah.
So thank you very much for watching, and thank you to my panel.
Thank you.